Recording in progress. Okay. Oh, this is the other thing that patients can tell if they have a partial knee versus a total knee. The one on the left can bend more. There's a slight difference, but to some people, they think that's a big difference. They'll like one knee better than the other. The general rule is the person who bends the most usually likes their knee the best. So you can see they both have good flexion, but one has better. The picture, the image, the x-ray below shows what a partial knee looks like compared to a total knee from 2011. There's another thing that patients may not understand, but partial knees tend to feel more natural. It feels like my knee, they say. It feels more normal. Total knee replacement takes the entire surface and replaces it, and in the process, you have to take or cut or remove the anterior cruciate ligament. The shape of the implant and the design keeps things stable from slipping and sliding, but that ligament does more than keep things from slipping and sliding. I call it a bundle of nerves that communicate between the femur and the tibia, and those who are more athletic, those who want to stop and start, turn and twist, change direction, they miss the anterior cruciate ligament. Even if the knee works, they feel that it's not quite the same and they can't explain why often. I absolutely believe that the number one reason is because most total knees are missing the anterior cruciate ligament. If you only replace the cartilage on one side, you can leave that ligament alone. So let's go over it all now. You can replace the inside between the legs, that's the medial compartment. And look, there's good cartilage around the other side. You don't need to replace the other side. It was bone on bone over here. You can replace the outside of the knee if the inside is good. That's a lateral compartment, partial knee. Or you can place something metal where the patella rubs, put a plastic button on the back of the kneecap, and do patellofemoral replacement. You can target any one of these, you plan it on a computer, and then you go in and fix just that area. So what does this allow you to do? Well, before the operation, you plan everything on a computer. If the leg is crooked on the x-ray, you make it straight. You can make sure if it's a size 4 that fits the person perfectly, then you're not going to put a size 5. And you don't judge with your eyes, you can judge before you get in the room, and everyone can see that you picked the perfect size for that patient, and then the computer will prepare for only that size. And how it fits on the bone, you can place it exactly where you want it, to the millimeter, not a little bit off here, a little bit off there, but exactly where it's supposed to go, and everyone can see that you put it in the place that you said you were going to put it. And here's how you do it. I'm going to talk you right through the technology, and I bet even if you don't have a medical background, you'll understand. The first step, trackers. As soon as you place those trackers on the bone, the computer knows where the femur is, that's the thigh bone, and the computer now knows where the tibia is. If it moves around in the room, it moves around on the computer screen. That's step 1. Now you have knowledge of that person's anatomy in the computer. It knows where the femur is exactly. Step 1. Step 2, I call it a magic paintbrush, a pointer. You touch the bone, the end of the bone, and you rub it around on the bone, and it starts painting a picture into the computer of the exact shape of your anatomy. Whatever your shape of your bone is now, the computer knows where the bone is in the room, but now it knows a little more. It says, the end of the bone is right here, and this is the shape. So that's a picture of the computer screen in surgery, and you're rubbing the end of the femur, and it's showing you the shape of the side that we're going to operate on. So it shows one side of the bone in green. That half of the bone is now stored in the computer. It has an exact image of your anatomy, not just we're doing a knee and here's an implant. This is the implant. The implant now will fit or be put on exactly your bone. This is the tibia, the lower bone. You paint it with that magic paintbrush, the pointer, and as you rub it on the bone, the green appears until you have all the details of the person's anatomy. Now, the good part. Now that the computer has your anatomy, you can start putting virtual implants onto the bone. You can move them around, wiggle them, and make them so they match each other. The femur matches the tibia. They're not too tight. They're not too loose. And you can see on the computer screen how that implant now fits your bone. So what did we do? We just added the implant. Now we have your bone in the computer. Now we put the implant on, but we didn't do it in your body. Before we put it in your body, we checked to see, do we really like that size 4? Or would a 5 be a little bit better for you? Which one fits? Do they match? Does a 4 and a 5 go together on this person, or do 2 size 5s fit better? You get a chance to move things around and make sure they rub together, that they're balanced, that they're smooth, that they're aligned right on your body. And you haven't done it to the person yet. You're in the room, and before you put them in, you can see how they're going to work. All right, now that you've made your plan and you think you have the perfect plan, here's the smart tool. The smart tool is a burr. That burr now knows the plan, and it starts removing the bone exactly the way you said you wanted to put on the implant. And as you burr the bone away or sculpt it, sculpt sounds better than burr, then you can see, the computer can see what you did to the patient. It can see the shape that you've prepared. If you were supposed to prepare for a size 4, you won't remove enough bone for a 5. If you try that smart tool, the burr will retract. It'll disappear from the field. Even if I want to remove a piece of bone, if it wasn't what we said we were going to do, you can't do it. The burr won't let you do it. So now you prepare the femur, now you prepare the tibia, and now you've actually done something to that patient. You've prepared the bone for the implant that you chose, and you've prepared it exactly according to plan. Finally, before you put in the real implants, you put in what we call a trial, a fake implant. And you put it in on the patient's body. You don't cement it in and make it permanent. And then you watch the range of motion. You can tell all this information about what you've just done to the patient. Is it too tight? Does it wiggle side to side too much? Or is it exactly the tightness and the stability that you like? How much bend are you going to get? You'll know all of these things before you put in the real implants. If a size 5 makes it a little tight and you don't get as much range of motion, then you may say, let me try a 4. And you can see if the 4 gave you more motion or if the 5 is more stable. All of those things before you cement the parts permanently into the body. Isn't that better than cutting it with a saw and then cementing it in and getting an X-ray in the recovery room? That's how it's done. Most places, 90% of the surgeons do mechanical tools. They cement the parts in and they get an X-ray either in the room or in the recovery room after they're in, and then they evaluate how close they came to their surgical plan. In 2008, we got a hold of this technology and we never let go. And now it's better than it was. There were years where we were doing this. I was the first surgeon in LA to do this. And many surgeons criticized. They said, it's just an expensive toy. We've been doing it this other way for years, and we do great surgery. We have great results. You're just taking more time, and it costs more. Well, here's something important for the patients. It doesn't cost the patient a penny more. If you do it with mechanical tools or you do it with this technology, when you use your insurance, they don't charge you $1 more for doing this compared to the traditional way of doing knee replacement. So now that I've educated everybody, I'll let you be the judge. Which is better, a saw or a smart burr? Number two, which is better? Which do you think is better? A metal rod to see if the leg is straight. You can look at the leg and say, hey, that looks really straight. Or in the room, a computer that says, you are exactly 1 degree off of what you wanted. You're half a degree off of what you want. Or the computer can say, you are exactly where you said you want to be. Which is better? And finally, last slide. What's better, using your imagination or using technology? Now, this is an interesting slide, and it's actually a surgery I did in Guatemala this year. We had no computers. We're doing charitable work, and this femur was broken. And the only way to give her a chance to walk was knee replacement. So I took a pen and my imagination, and we drew a plan on a piece of paper. We posted it in the room, and we made a knee replacement, and it worked. So I say that out of humility. Number one, there are great surgeons that don't use computers. Their hospital won't buy the computer. They never were trained to use it, and they're doing good work, and they don't have a computer. So I'm not criticizing the fact that most surgeries are done without it, without robots. You can do good work. And there are times where I do it that way. When we go on these charitable trips called Operation Walk, we don't get to bring our technology, and we still believe we help people. So it's not a criticism. I'm not saying that one way is the only way to do it. But of course, you better believe, I believe that when I have a choice, I want to use the technology. So I'm going to close with this slide. I can't help it because this is my other life's work. Something you should look up: Operation Walk. That smiling woman, that's whose knee we fixed with that drawing. That's her, standing again, walking. That other room is full of patients that otherwise would have had no chance of walking without pain. And that man is up now out of that wheelchair, and he has a knee replacement that works. So there are times where the surgeons that don't use the computers have an advantage. I tell them, I look up at home, I look up on the screen, and I have my little perfect machine with perfect alignment. But now we're here in the trenches, and you're used to doing it without the computer. You have an advantage over me. And I respect that. I respect the fact that it's an art as well as a science. But I believe that in 2021, that this technology is the best way to give people all the choices they need to get the best operation with the least risk and the possible best outcomes. Thank you very much. That's the end of my lecture.
Thank you, Dr. Long. I just sent out a message to our attendees to see if they had any questions. So far, no questions. So I'd like to take this opportunity to thank you for joining us again this year and hope to see you very soon.
Well, thank you very much for having me and for rescuing me from my PowerPoint glitches, because the computer
rescue you.
The computer had me scared.
I understand. I understand that. I feel the same way about that Apple computer in front of you.
All right.
So take care. Thanks again.
All right. Thank you.
All right.